morning and good afternoon. I'm Dr. Jill Einstein, Senior Director of Physician Engagement at MAVEN Project, and I welcome all of our physician volunteers here today to learn about the art of responding to consults with MAVEN Project. It's my pleasure to introduce your fellow MAVEN Project volunteer, Dr. Scott Abramson. And I'm going to read to you a little bit about Dr. Abramson's bio. So Dr. Abramson retired from Northern California Kaiser Permanente after practicing neurology for over 40 years. He attended medical school at the University of Georgia in Augusta, did his residency in neurology and neurophysiology at Downstate Medical Center in Brooklyn, New York. For over 25 years, Dr. Abramson has been passionately involved in the communication and physician wellness projects at Kaiser Permanente, where he served on the regional board of physicians for these endeavors. He has delivered dozens of workshops and coached scores of physicians and staff, and he has written and developed programs on time management, teamwork, difficult conversations, physician to patient communication, physician to physician communication, and staff to physician communication. And in 2022, Covenant Books published a compilation of his writings in a book entitled Bedside Manners for Physicians and Everybody Else, What They Don't Teach in Medical School or Any Other School. And these articles touch on topics such as listening, connection, faith, bereavement, death, teamwork, empathy, and so on. So Dr. Abramson, thank you so much for helping to teach us and to gather us and engage in a great discussion about MAVEN Project. Thank you so much for being here.
Well, thank you, and Jill, and I'm very grateful to then be a member of MAVEN Project, and I've been taught by so many of the volunteers here and learned so much from them. So this is about how we can make our e-consults even better. And we've sort of compiled some simple do's and don'ts. This is a compilation, not just of my suggestions or Jill's suggestions, but we've also talked to other volunteers and gotten some of their input. So what you're going to hear is some of their input, along with let's see. Oh, okay. So just first off, just imagine what the challenges are of the people that working in these underserved clinics. What in their daily life, what are some of the challenges? Now, I want you to we're going to just cut this down to maybe about 15 seconds and maybe try to think of just the first or second thing that comes to your mind. What are the general challenges of someone? And we have so many people involved, we're not going to be able to go around to each person. So what we've done in this, and it seems a little bit hokey because we're going to ask for your input, but we already have some input from a lot of the volunteers that have shared that with us. So what we're kind of going to be looking for, and you'll understand this as we go along, is what else? What did we miss? So let's start. You'll see how this goes. We've got a couple questions like this. So let me give you about 15 seconds. The first thing that comes to your mind, what are some of those challenges?
Scott, would you like people to write in the chat or just jot it down?
No. I'd say chat it. Oh, I'm sorry. Chat it. Write it down just on a paper and pencil, paper right at your desk. Just write it down. No need to chat that. But if there's something new, then chat it into us or raise your hand in a verbal chat. Yes. New? Well, the first things that come to your mind, what might be their challenges? So you'll see how this works. Okay, so here are some of the thoughts that we had gathered prior to this. Imagine what it's like seeing a patient every 10 to 20 minutes. These patients often change clinics, so the medical records, they may not have optimal medical records. They may have a lack of available clinic. We've heard that so many times that, gosh, I got to wait 3-4 months for a neurology consult. They may be in an unsafe part of town. People may, have to want to leave before the sun goes down. The staff may be overworked and suffering. They are in healthcare systems that give them little control over schedule. I'm sure you probably have heard that from people that you've mentored. Any test they order may have to go through a bureaucracy of approval. Any test they order, the patients may have to pay for it. So did we miss anything here? Did anybody write anything down besides this that we missed? And I guess either chat or raise your hand. I can't see that. I can't see the hands, but I guess Jill, you could, or Kristen, you could, or the chat.
There are some things coming in through the chat.
Okay.
And so we have different language.
Different languages. So many people. Jill or Kristen, could you write these down so we could add them to this after this is over?
Yes.
Okay.
And lack of access to some testing.
That's right. Exactly. Great suggestion. Right.
Complexity of cases.
Yeah, boy, how many times have you had a nurse practitioner send you this complicated case that it's not even, suitable for an advanced internist. It's like a specialty case, but they have to handle it. Absolutely.
Their own knowledge base. Health literacy.
Yeah, health literacy, right. These are underserved. Man, you guys are coming up with some great stuff. Yeah, health literacy. A lot of these are in parts of town where, areas where people don't have good health literacy.
Mm-hmm. Inadequate support staff.
Inadequate support staff, support staff that's burned out or whatever. Yeah, absolutely.
Yeah, they see a patient and have no idea what to do with it. They have consultants who suggest an expensive medication, which the patient can't afford.
Yeah. Well, I think that's going to come back into some of these. That's going to be repeated in some of these other things. So, man, let's add those things after this is over. Kristen, if you can write those things down, that's great stuff. Let's move on. Okay, so imagine what are the barriers when sending a consult to MAVEN. So, like I said, we have some input on this, but think for about 15 seconds and just write down the first or second thing that comes to your mind. Okay. So here's some of the thoughts that we got from our colleagues. They feeling intimidated. We're old geezers. They're young bucks. It's kind of hard. Fearing that they may lack knowledge that about the thing that they're going to think. They don't want to appear stupid. Embarrassed that they not have more background history because they don't have medical records. These people change their thing. I mean, if you're a clinician there, these are the things that may be going through your mind. It takes time to write out these consults and send them in, and they're pressed for time. Maybe they even got an unhelpful or even a condescending consult from us in the past. Anything else? Okay, that's okay. And if you think of things, after this, this would be a great thing to share in your breakout rooms too. So keep this in mind. But these are some powerful things that can prevent someone from making a consult. So here's some suggestions. We put some suggestions from your MAVEN colleagues, and we've got some do's and don'ts. And here's some of the do's. Thank the clinician. Compliment the clinician. Apologize. Make an empathic statement. Validate. Couch with suggest language. We had initially put suggestive language, but Jill said that's not quite appropriate. We don't want to use that word. So we said suggest language. Close with a path to follow-up. Promote the MAVEN Project. These are some of the things. Now, here's the thing. It's not that we're saying do every one of these things in every consult, but maybe in each consult you do, pick one of these things and just it's a value-added thing. Here's some of the don'ts. Deny the consult for lack of complete information. Recommend out-of-scope practice. Somebody said this, out-of-scope practice test. Expound upon the zebras. Use excessive jargon. Delay sending the consult. And equivocate or be indecisive unnecessarily. Okay, so let's start from the beginning. What can you thank the clinician for? What can you thank the clinician for? Think for about first thing that comes to your mind, 10 seconds. Okay, let me give you some of the responses we got. Whoops. Thank you for consulting MAVEN. Thank you for taking time from your busy day to make the consult. Thank you for allowing us the opportunity to help you. This gives meaning to our lives. Gosh, I mean, I don't know about you, but it's so true. I found so much, now that I'm retired, we all, I think, look for something positive to do, something to make the world a little bit better. And this is one of those things. And I'm thankful to these clinicians in these clinics that give me the opportunity. I'm thankful to MAVEN. Thank you for giving a good, complete case history. Anything else? Did anybody write down anything else? This may just be the beginning.
So thanking them for the work they do.
That's right. Thank you for all. That's great. Thank you for the hard work you do under the circumstances that you do it.
Mm-hmm.
Absolutely.
Going out of your way to help the patient. So thanking them for going out of their way.
I love that. I love that. Thank you for helping your patients in this way. Great. I love that one. Yeah. Okay, how can you compliment? How can you compliment and it's sort of an overlap with the first one, but I don't know, think for what comes to your mind in 10 seconds. Okay, here's what we came up. Thank you for a good case presentation. There's some overlap here. Thank you for the good questions, the specific questions you asked. Boy, you had a good presentation and you asked me good questions. Thank you for the good research. Great job on the research. Thank you for the hard work. This came at 6 o'clock of your time or something. You're staying over in clinic. And thank you in this frontline clinic so there's overlap with the compliments and the thank yous and so forth, but this is the gist.
Also, thank you for their thoughtful evaluation. Thank you for reaching out on this difficult case.
That's right. Thank you for that's right. That's right. Okay. Apologize. What can you apologize for? 10 seconds. First thing that comes to your mind. Okay, here's the things that your colleagues thought about. Not being, how many times have you just not been able to give a good answer? Gee, I'm sorry. It's just one of those things. And of course, when someone gets an answer, even that the expert of 40 years experience doesn't know, it makes them feel better. Gosh, even the expert didn't know. I feel better. I'm not so stupid. I'm sorry, I'm responding kind of late to this request. I know now it's a little bit different on the platform because we have to respond within so many hours, I think 24, 48 hours, something like that. But if we're responding at 47 hours, gosh, I'm a little sorry I got so late. Anything else to apologize for?
Not being there to help out. Sorry that I don't have the knowledge, but let me try and reach out to another colleague and we'll get back to you.
Yeah, right.
And I just wanted to remind the volunteers that if you are really stuck on a case that's out of your wheelhouse and you know a specific volunteer within your specialty group, you can forward the case to a specific volunteer. Right now with our platform, you are not able to forward the case to another specialty group, but you can always write back a brief note to the provider that says, please also submit this case to someone in our, X specialty group. And so that they'll know to resubmit the case to another group. Mm-hmm. And if you can give a partial answer to the best of your ability, to include that as well.
Yeah. And I would say that even if it is in your wheelhouse, but you're saying to yourself, man, I mean, I think I know the answer to this, but boy, I'd like to hear some of what my colleagues in my specialty might say or might add differently. Gosh, we've got these great resources. We can learn so much from each other. Empathic statement. What empathic statement can you make? Must be tough, blank. Fill in the blanks. Think for 10 seconds. What's the first, second thing that comes to your mind? Must be tough. How about this? Must be tough having specialists unable to give support when you need it. Having no background medical record. Picking up a new patient with a long, complicated history. Many psychological issues. A lot of their patients are with drug and alcohol. Patients non-compliant. Must be tough working with a short-staffed clinic. Anything else that you wrote down? Okay, again, these are things that you might want to think about in the breakout room and add to this.
And Scott, here are some. This is a challenging situation and case.
Yeah.
The need for social work to assist with support.
That's right. Boy, yeah, it's really tough because you may not have all this backup social work and drug counselors and everything. It's got to be tough to handle this thing alone. So validation, what kind of validation statement can you make? And again, what we're saying is, you don't need to put every one of these do's, but think about putting one or two of these do's in every consult. So think about that. What kind of validation statement? Here's some of the things that you're right. Yeah, you mentioned that patient might need to see. You're absolutely right. They need that test. Boy, that isn't. I think these three words, "you are right," are even more satisfying to hear than "I love you." What better thing can you hear than "you are right"? It's tough for me too. Boy, I see you've got this up. I'm the expert, and I'm stumped too. Wow, if you're that clinician on the other side, you're thinking, God, I may not be so stupid. Anything else?
You have done an excellent job with your differential diagnoses.
Yep, that's a good one. Yeah.
You've done a great job so far.
Yeah. Okay. And this is so the validation kind of bleeds over to the compliment part, but there's a specific validation to element to this thing. You're right. Boy, it's tough for me too. Right. Okay. Use suggesting language, not directing. So it would be this patient should have test X versus, I would suggest patient have this. Unless, of course, you feel that it really does need something. So here's what the upshot of that might be. A clinician in one of these clinics might say, the MAVEN doctor said I should order this test, but I really don't think the lady needs the test. Besides, it's expensive. She has no coverage. I don't know what to do. I feel bad about ordering it and feel bad about not ordering it. So sometimes when we have this thing, you should do this, you should do that, unless we're really certain that should be done, it might be better to use suggest language. Okay, close the encounter with a pathway to follow-up. Give clinician a pathway to follow-up in some way. Now, please contact me within 7 days if you have any further questions. Now it's easier with the new portal to do that. And promote the MAVEN mission. Thank you for sending us. We look forward to collaborating with you. Encourage your colleagues. It's just a one-liner to put in there, but we want to help people and they need help. Okay, so here's some of the consequences of these do's, right? Here's what it might look like. Hello, Maria. Thank you for consulting MAVEN. Thank you for such a complete review of the patient's history. A compliment. Boy, empathy. It must be so tough to have to wait 3 months for a consult. And you are absolutely right. A validation to ask this question about the radiology. Let me suggest language, what you might be helpful. Here's the consequence. Boy, I tried this MAVEN thing out last week. It's fantastic. I got good advice, and the MAVEN doctor was so nice. She made me feel so good, like I wasn't like I've heard so many sort of buried in some of these consults. Gee, I hate to bother you, doctor. Doctor, I hope I'm not a pest. Doctor, maybe, so we can validate these things, and we can. This is some of the consequences when we add some of these do's. And I know some of you are already doing it and doing it very, very well. And again, that's what I'm saying. We don't just do everyone. Okay, so let's talk about some of the don'ts. And we're going to look at this as in the terms of what the consequences of when you do these don'ts, what are the consequences to our clinicians in the clinic? So don't deny the consult due to lack of information. So this is version 1. Marie didn't mention the blood pressure. It's difficult for me to reply without that. Please get back to me when you have that information. Here's the consequence. So he needed more information about this pressure. I said he didn't feel appropriate to render an opinion without it, but I was real busy and his patient's really hard to get in the clinic. Besides, she struggles. So I forgot the whole thing. On the other hand, if you do version 2, it's, the ortho was not commented on. It might be helpful, but let's assume it was this. Well, I would suggest pathway A. Let's say there were orthostatic changes. I would suggest B. So one of these don'ts is try not to deny the consult. And someone had brought this up before, recommend tests outside the clinician scope of practice. Great question. How do you know if the tremors, I had to use neurology examples because that's what I'm familiar with. How do you know if the tremors from Parkinson's or from Haldol? Order the functional neuroimaging for the dopamine transporter, DAT, order a PET scan, ask them to assess the striatal DAT, all this stuff, blah, 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 blah. Thank you for this challenging consult. I'm happy to help you. But this clinician is not used to ordering this test, I would assume. So this is the upshot of it. The doctor told me to order this test I never heard of. I called radiology. The radiologist started asking me these questions. I felt like a fool. And then the clinic manager got on my case. Whew. All right, don't expound on the zebra differential. Yeah, you're absolutely right. Nice validation statement. These are migraine headaches. However, let's be 100% sure we're not dealing with some unusual form like a colloid cyst, like a low-pressure hydrocephalus, cryptic CSF, CADASIL, blah, 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 blah. I'll detail the workup for those in the paragraphs that follow. We're going to, they don't need to hear the zebras. So I asked the MAVEN doc about a lady I thought had migraine, just wanted to confirm. And then I got this 3-page response about all these other things. Honestly, I didn't have time to do all that. I kind of feel guilty now. I'm going to think twice before sending another consult to those MAVEN people. And I'm guilty of that too. I've gone through the zebras too, and I look back on those consults. I shouldn't have. They babble with the excessive insider jargon, well, they could represent normal pressure hydrocephalus, of course, whether this represents non-communicating obstructive hydrocephalus or communicating hydrocephalus, communicating non-obstructive. Maria, I hope this has helped. Boy, that MAVEN doctor is really smart. I think he was a professor someplace. He wrote all this stuff about how, honestly, I didn't understand anything. I feel kind of stupid. I guess I'm just going to have to wait another 4 months till Dr. You-know-who can see my patient. So we got it. Sometimes we're so used to that jargon, we use it in our daily language, or we have used it for so long that we forget that other people may not be there. Don't delay sending an e-consult response. And I've done this too, I picked up this e-consult, turnaround time. We'll check out maybe tomorrow. I'll send it in tomorrow morning. It's not really urgent. Okay. But let's say you take the other approach and you answer it that same evening, maybe during halftime of the Warriors game or something. Boy, that MAVEN consult was fantastic. Like within 2 hours, I got a response. I was still in the office. I called Ms. Ramirez. She was so relieved. I'll be sending more consults to this MAVEN project for sure. So, when we send these things promptly, not only are we giving sustenance to these clinicians, but we're helping their patients so much to get. Can you imagine Mrs. Ramirez? She's all night long. She's worried about this funny MRI or something that she doesn't need to worry about. Don't equivocate or be indecisive unnecessarily. So, it's great to give options, but you got to try to commit to something. Well, Maria, thank you for consulting the MAVEN. Compliment, you presented it very clearly. Nice compliment. Here are my recommendations. You could do A, or perhaps B might be a good option. And yes, others might suggest C. So what's the upshot? The MAVEN doctor was very nice, very supportive, but honestly, I still don't know what I'm supposed to do. So here are the e-consult. Let's just go over these again, the do's and the don'ts. And there's some overlap here. Remember, thank the clinician, compliment the clinician, apologize when you have to, make an empathic statement, validate, wow, you're right. They do need this. Gosh, this was tough for me too. Couch with suggest language, close with a path to follow up, promote the MAVEN mission. And sometimes just putting in that statement, we hope we've helped you. And gosh, tell your friends about us. We can help them too. But of course, the best advertisement is word of mouth. The best advertisement, I saw this someplace on a bumper sticker, says the best advertisement is a satisfied customer. Let's satisfy our customers. Deny the consult for lack of complete interest. Recommend out-of-scope practice tests. Expound upon the zebras. Excessive jargon. Delay the consult. Equivocate. Okay. Here's another thing that came up. So you've written this consult, you put a lot of time and effort, and something goes wrong. The consult that you worked so hard on gets lost in the internet, and then you have to write the entire brilliant consult over again. Believe me, that has happened to me too. So consider this simple fix. Write your consult on Word or notes, save it, and then copy it and send it back to the clinician. That way you'll never lose your written consults. Yeah. So that's the sort of formal presentation. And what we hope to do now, any questions or comments in general before we go on and talk about what we might do in the breakout rooms? Okay, so what we thought is that we divide into some breakout rooms and talk about these things. Okay, and so one of the questions we know that people came up with, and one of the things that people wanted maybe to talk about more was, boy, that MAVEN doc is very nice, but it's just kind of hard to follow her advice sometimes because it's written like an essay. So one of the questions you might want to ask in your breakout group is, what's the best way to bring organization to your consults? Or here's another one. Some of our volunteers have talked about, how long should these things be? And here, I had a few questions. The MAVEN doctor sent me a 3-page educational background and all sorts. It was really nice, but I didn't have time to read that. So what determines the length of a consult? When's it too much? When's it too little? So that might be another topic to talk about. How long should consults be? And finally, these are the do's and don'ts. And so what we would suggest is, when you go into your room, talk about maybe the organization, if that's an issue for you. How long should a consult be? Maybe you want to discuss some of these do's, some of these don'ts, and then we will come back together, and then maybe have one person as a spokesman for each group and sort of discuss the highlights of what you discussed. And maybe you have some more do's to add. Maybe you have some more don'ts to add. I would caution you about one thing, though, is when you're having these discussions in your room, it's not going to be, I don't think it's going to be helpful for the process to focus on the negative. In other words, to focus and say, this do number 5 is just not going to work. It just doesn't work, doesn't make sense, and so forth. I mean, it may not make sense to you, and that's fine, but unless you can make it better, unless you have an idea to make things go forward and be better, I think that's the more valuable discussion to have, not to report on the negatives of any one of these, unless there's a way to improve it. So those would be the things. The how do you organize it? How long should it be? Discuss any one of the do's or the don'ts, and then we'll have that discussion in your room. Jill, is there any way we can put this slide up there so people can look at this while they're talking?
I don't think there's a way for me to take a
Oh,
screenshot and then place it, and I'll give a try once everybody's in.
well, why don't we just? I tell you what. Why don't we just leave it up here for about a minute or something, and people can just write it down. Maybe some of these things that interest them, and they could take it into the room with them. With
That's
that.
great. And as people are looking, there were just a couple comments and questions in the chat. Should we tell the clinician if they have ordered tests which should not have been ordered as a learning experience if we don't come across as negative? Yes, so I think that as long as you do it in the constructive and the positive, not like what they shouldn't have done, but what they should do for the next time, just in a gentle tone. And tone is definitely very key in any response.
Yeah.
And then a templated message promoting MAVEN Project. So yes, you can create several lines that you might use in almost every one of your consults, whether it's part of your greeting or part of your end, and that you could kind of plug that in at the bottom of your consult message.
Mm-hmm.
So great. So the next step that's going to happen is that we're going to go into breakout rooms. Once I click the button to open all rooms, you'll receive a notification and you'll click on that and it'll take you into a smaller room where you're going to be meeting with there'll be groups of 2 to 3 volunteers. And please first start off by just doing some quick introductions, a little bit about your background and where you're located, and then sharing your experiences about consults, what's worked well for you, what hasn't, and maybe have one of you kind of take notes, because when we come back together, we'll share that information. Shirley, I have you in a room. You can pop in and out if you want to. And let me just double check the rooms now. I just need to do some reshuffling. So hold on just one second here. I'm just going to move some people.
Jill, let me ask. So Jill, we're running, I don't know, we're running a little ahead of schedule. Do you want to do, how long do you think would be good for a breakout room?
I think 10 to 15 minutes would be just fine.
All right, let's do 15.
Okay. Okay, great. So I'm going to go ahead and send you into your breakout rooms, and then I will notify you when you come back in, and then you'll automatically be pushed back into the big room together. So here we go. And Martha, I'm going to put you in a room. Just give me a minute here. Welcome back, everybody, from your breakout sessions, and I hope that you enjoyed getting a chance to meet your fellow MAVEN Project volunteers and discuss some of the challenges and some of the pearls of wisdom that you could share with your colleagues about responding in an effective way to the clinic providers. And I'm going to turn it back over to Dr. Abramson.
Mm-hmm. Okay. I was in one of the groups and there was some very interesting discussion. I don't know how to.
I'll go ahead, Scott,
leader.
and I can go around. I have them actually, the room, they didn't know that they were numbered rooms, but I'll first start off with room number 1. And this is Gail Kaufman, John Mazzullo, and Philip Rapport. And if one of you could share a few things that came out of your group.
Well, I guess I can start because this is Gail's first experience and she hasn't done a consult yet. So we spent the first half of the time getting used, talking to each other and getting to know each other. And then Phil had trouble with his microphone and audio. And then he finally came in and he stopped Gail and me in our tracks and said, why don't, as a way to get started, wouldn't a good thing be just to give them the section from up to date? And I didn't know what to make of that. It didn't strike me as being the nature of the consult that I would have thought would be appropriate for our people, because they're usually PAs and NPs that are within the first 5 years of their practice.
I didn't exactly say that, though.
What did you say?
What I said was, when I give a consult, I sometimes, to back up what I'm saying, I'll copy and paste a small section of up to date, maybe 1 or 2 sentences.
Oh yeah, yeah. That you would give them
Put it
some
in there and
stuff, yes, as a backup.
I give it credit too. I always say it's from up to date.
Yeah,
Okay.
and Philip, that is a great tip. So that you can copy if you have access to up to date, and we are working on possibly getting this for you in the future, access to up to date. But you can incorporate that into your consult. But again, just like Philip said, a short section or a link to that particular section, but really they appreciate your interpretation. We actually recently got feedback from a provider who says, I got a consult back from somebody and they just literally just copied and pasted from up to date, and that wasn't really what I needed. I needed to know how to approach this particular case. John, anything else from your group?
No, I think that's exactly what we talked about, that this was up to date, might even be a little too sophisticated for some of these people because they're right out of school. And that what they really want from us is to be pointed in the correct direction and to get going on 1 or 2 things that they can do and have an order about things. I don't think they're very interested in the pathophys at this point. They basically just want to do the correct workup and get in the right area where they're going.
Great. Thanks so much, John. And thank you, group 1.
Yeah.
Our second group.
Jill, if I could just add just quickly, John, I think, this up to date is really a body of knowledge. What they want from us is our wisdom. We've done this stuff. We know what's important, how to use what's important. They want our wisdom, not our knowledge.
That's exactly right.
Yeah.
Good way to put it, Scott, as always.
Great. Now, group 2 is George Minawata, Bob Lohr, and Susan Hubble. And Bob, I know that you got to meet 2 new MAVEN Project volunteers, so I hope you were able to impart a lot of your wisdom with the group.
I don't know how much wisdom I imparted, but I did get to meet them, and they're very nice folks. Susan is brand new to MAVEN and is in PM&R, and George, pulmonary and critical care, also new, and neither of them have done any consults. So we talked more about the organization of the consult, and in terms of length, I'm a strong believer that less is more. You need to say what needs to be said, but you don't have to drone on forever and ever. We talked about making sure we understood what the question that we were asked was, and that we answered the question. I think, just as Scott said, they're not interested in a long differential diagnosis, 20 things, 19 of which are extremely unlikely. They want to know the one thing that we think is going on, and then they want to know how we would manage this. So, some discussion is great, but you don't have to, describe the physiology of normal pressure hydrocephalus, as Scott was talking about before. And then at the end, I think it's very prudent to make your recommendations actually as a list. And you can say suggestions. I use the word recommendations, but they are suggestions, really. Number 1, this. Number 2, that. Now, if there is some incomplete information in the original presentation, you may have to suggest number 1, and if it's normal, we would do this, and if it's abnormal, we would do that. So you can branch off a little bit, but you always should have a chain to get to the conclusion that you want to get to. And then I will just reiterate too, that validating the work that the clinicians have done and in a short time and under kind of duress is always a good thing to do. So I don't know, Susan or George, did you have anything to add to that?
Nope, good summary.
Okay. Thank you so much, group 2. Those are some really wonderful suggestions. We'll move on to group 3, and this is Loan Nguyen, Paul Kaplowitz, Pratima Misra, and Marty Wunsch. Okay.
I am the spokesperson for group 3, and we focused on the path to follow-up. I just joined MAVEN a month ago, and I'm a veteran of 3 consults. But my first consult was a bit disconcerting because, it was a relatively straightforward question. And then when I got my second consult, I noticed that the first consult was still open, and I'm thinking, why is it open? I had answered it, and it turns out that the consult remains open until the provider, decides to close it. And in this case, I really hadn't gotten any feedback. And, we are, all agreed that it was important for us to get feedback, immediate feedback. And in other words, we, ask the provider to please let us know, if they found, that they received our consult, and, whether they need any additional information, and also to request that when additional information becomes available, such as, we requested a treatment, and we would like, in a month or 3 or 4 months later, for the clinician to get back to us and let us know whether our advice turned out to be helpful. I was joined by Pratima, who's another pediatric endocrinologist, and Marty and Luan, who are both, Marty is new to MAVEN and hadn't done any consults, but Pratima, do you have anything to add?
Oh, Pratima, you're on mute.
Yeah.
Okay.
I just wanted to say we did realize that clinicians who are sending consults are very busy, and they probably take our advice and kind of move with it and not necessarily tell us the follow-up always. Or maybe sometimes some of these patients are referred. Some of the clinics have referral centers available to them, so maybe that's why we don't get the follow-up. But it's always nice when you do get a follow-up.
That is, and again, you can have sort of standard language as you're closing your consult that says, please let me know what happens with the patient, and so they can do that. As I just put in the chat that the consult is automatically closed after 7 days, and this allows MAVEN Project just to count all the great work that you're doing, so that to give you follow-up after 7 days, they would just resubmit the consult, and if they can, refer to the original encounter number so that you can see what you've written before. Also, as a reminder that all of your completed consults are in your inbox, and they're on another tab that you can actually go click into what the consult was and what your response was. So those are always available to you. Great. Well, thank you so much, group 3, and we'll move on to group 4. So Jermaine Defendi, John Farnan, Ved Gosain, and Bill Stroll.
And Jill, we didn't really have enough time to determine who was going to be the spokesperson, but I've elected Roger to be our spokesperson. So
I'll start. I think
Great.
the do was to answer your consult starting in a word processor so that you can paste it in. The advantage I've found is that it allows me, particularly under the initial portal, to organize it better so I can highlight what are the recommendations to answer the question and what's the discussion. And then the follow up to that to do was to give a pathway as to how they now reply. Before it used to be, send me a chat. Now it's, I will say, if you have further information, questions, or follow up, send me a reply via the portal so they know how to do it. And because I think on our end, we are confused as to how they're supposed to get back to us. So I think the people asking for the consults have an equal trouble that says, all right, how do I get back to them? Do I send them another consult? Does it get to them? And I think that was the biggest thing. Is also, I think we discussed how in answering it may be good to understand that many of them have limited resources and start with that. If they have more resources and can do, they have genetic counselors within their group, which is unlikely, but fine, suggest that do that, but to try and answer the question, assuming they don't have a lot of resources for the patient. Others in our group?
No, I think that covered it very well, actually. And it was sort of also an introduction because we have a new member that just started, just to give some ideas of what we've been through and what the program is about and such. That was excellent.
Great.
Jill, let me just ask you this. So people have wondered, we see an interesting consult. We want to know, a month from now what happened, and we ask the clinician to send us a report back what happened with our advice. But it strikes me that imagining these clinic days and the pressures that people are under, it's pretty hard for them to remember that this particular consultant wanted a follow-up. Is there any way for us, let's say, what I do is I keep a list of those very interesting consults, and I say, what here, and then maybe a month or 2 months. I used to try to email them and ask them, but is there a way that we can request follow-up directly without putting the burden on them to remember all these things?
So that's a great point. For those of you that volunteered with MAVEN Project before June 15th and you were on our previous platform called VC, there was a chat function. Not all of you knew it was there or knew how to utilize it, but you were able to initiate, and they could initiate a chat. On the new platform, our community portal, we currently don't have that function between volunteer and provider, but this is actually on our list to possibly be able to roll out. One part that's difficult is that there's we want to make sure that the providers are not initiating any new consults with you on a side chat. Because again, it's really important for MAVEN Project to collect data to show your impact. This is helpful for us just in general to see our growth as an organization, to follow provider utilization numbers, and then also with our fundraising too, to show all this great work that you're doing. So I do want you to know that that is on our radar, and then we'll just keep you posted, and hopefully we can get this. I'm not sure if this is in the very soon or if this is going to be kind of months down the line, but for you to be able to just send a chat without it affiliated necessarily with a specific consult, but that'll be a great thing. And then also another reminder too, is that when you're working on one of your consults, as Dr. Kwong mentioned, that he's writes his consults in a Word document, and then he copies and pastes just as like an extra backup for, in the rare chance that you could lose a consult, your hard work in a consult. But there's also, in addition, there is a draft feature so that as you're writing your consult that you can click save draft. And then there's when you're in your inbox, there is a tab that shows your drafts. And that's where like if you had to step away from your computer, when you come back, that's where your consult is that has not yet been submitted, but you've already started writing. So I also encourage you to use that draft feature.
Jill, this is Phil. Is it still possible to suggest with complicated cases, a brief video chat with the consulting physician or nurse practitioner? That would be more similar to the mentoring situation, which I enjoy, where you have a one-on-one conversation about the patient.
Yeah, that's a great idea as well. So again, you may want to have some standard language that you always put at the bottom of your consult, like, I'd appreciate follow-up. And then also like, I'd be happy to discuss this case with you via video consult. And so they would need to sort of resubmit as a video consult directly to you. So they need to select you, not sending it to the group or the room. And that's a really great suggestion. Okay, great.
Jill, really quickly, would you have to have consent though, if you were to do a video of the patient, or let's say you're looking, let's say a neuro platform, if there's a concern of ataxia, and you'd have to get a video of that to relay to the MAVEN volunteer. Is there an issue of consent?
So you're so when I think when Bill Searle was referring to video consult, it means a video consult with a provider for discussion. And again, it's provider to provider. So you should never be interacting with the patient. this because MAVEN Project Foundation is built on this provider to provider model that complies with cross-state telehealth regulations and also liability. So, you are all covered under our umbrella liability insurance.
Okay, thank you. Sorry, it was my mistake.
No worries. But that's that's a great point.
Yeah, thank you.
Okay, great. Well, thank you so much for group 4. Moving on to group 5, Charles Norris, Daniel Dvorkin, and Lois Friedman.
We didn't set up who was going to speak, but I think I was the oldest in the group in terms of MAVEN years. I guess Daniel is brand new and has yet to do a consult, and Charles has done several. So we talked a little bit about what kind of information we get, how we try to indicate what more complete information we might need to help them better. Talked a little bit about mentoring as well. And the fact that in mentoring, there's a relationship, whereas with the consult, it is, as opposed to consults when you're a hospitalist or a person doing consults in a hospital and you develop relationships ongoing with house staff. These kinds of consults are really more fact-based. So you do miss the relationship piece, which I think indicates why we all want feedback, because we want a relationship, but the providers are really focused on getting the answer and moving forward. Charles, Daniel, do you have anything else to add?
Well, we also talked about the fact that Daniel is a dermatologist, so he needs to see pictures of skin conditions in order to be helpful in his consults. But even in psychiatry, the couple of the consults I got were the question was, patients not responding to their antidepressant, and their answer was because they had not asked about bipolar depression and didn't seem to have that background and knowledge. So I approach it a little bit like the Socratic method with the medical students of, there's 2 kinds of depression, and then I supplied them with a screening test for bipolar, and I said, check out this, and if it sounds like they're bipolar, and they may need a different type of medication. So trying to follow the don'ts of not giving too much, but at the same time giving enough to answer the question properly and look in the right direction and how to proceed.
I think like a lot of others have observed, we're dealing with practitioners that are overloaded, that are pressed for time, and it seems like they could be best served by being extremely practical and trying to be as concise as you can.
Great. Thank you so much. Wonderful. We'll move on to the next group, group 6. This is David Dorsky, Kevin Martin, Ram Chowdhury, and Scott Abramson. I think you were in that group too, but I'll let somebody else from your group speak up.
So I'd like to just briefly summarize what we spoke about. We sort of have a problem with the quality of the information that's provided with the referral for the consultation. And Dr. Chowdhury and I are both ID doctors, so we often get these diffuse, complicated cases. And we certainly don't want to discourage use of our service, but I would just wonder if there's some way of coaxing the providers to improve the quality of the intake information, and whether there's some sort of template we could provide. And we don't want to be punitive in any way. We want to be helpful and supportive and all that, but it would be nice if there were some sort of guidelines provided to them so that they would kind of know what we're looking for in some ways. And I know it would be hard to generalize across all subspecialties, but I acknowledge that this is sort of above my pay grade, because it would have to be, platform wide. but I think that we could be of more service if we had more information, and we don't want to go back and, ask people these nitpicking questions. We just want them to think through the referrals a little bit more. And if maybe there's some way of doing it, maybe there's not, but I would like to submit that for the management, so to speak.
Great. I think that is a really great and important point. We have actually put together, I think it's maybe about 1.5-page document of guidelines for providers to respond to e-consults. I have not shared it or submitted it to the greater providers yet. I'm struggling because we started off with like maybe 10 points that were super brief, like each one line each. And then I asked for input from multiple volunteers. And it is the same refrain, and an important one: we need more information about the about the patient. And then this document ended up kind of getting longer and longer, and it almost diluted some of the other points and suggestions. And we've always struggled with, we don't want it to be a barrier, like if they're expected to provide every single piece of information, a barrier for them to submit. But on the other hand, as someone mentioned, a lot of the providers are on the newer end of their career, have not had practice, have not necessarily had in-depth training, and don't have a seasoned provider in their office. And so they're not even used to presenting a case verbally or writing it out. Yeah. I mean, you're just like, did you learn a SOAP note or not? And oftentimes it's not. So it is on our radar. I'll, talk more or look into how we might share this guideline document. And also, we're working on ways for the providers to more easily gather or grab information from their EMR and share it with you without including the protected health information. So sometimes, like, they may not be facile with like knowing how to do a screenshot where they're sort of avoiding, the medical record number kind of thing. So what I would say, though, is, to the best of your ability, attempt to give them an initial response. And you can say, again, like Scott said, like, based on the information you've given me, this is my impression, this is my suggestion, 1, 2, 3. Ideally, I'd love to know the following 1, 2, 3. And sometimes they answer and sometimes they don't. But that's a really great point. Thanks for raising it.
And Jill, I would add that, and I think David does something extraordinary in those kind of consults that seem kind of inadequate information. He says he invites them personally to share a video consult with him, and even gives his cell phone number on some of these things. I'm not sure I would go that far, but that, I think that's extraordinary to do, David.
The other comment I would make is a lot of them are seeing the patient for the first time. And it was a problem, like somebody had latent TB for 5 years known. Suddenly they want to put the patient in medication. And I had to explain to them, this man, he or she is still drinking and alcohol, and you need to get to know the patient better before you jump in and give. It's not an emergency, but for them, they have to do something because there's a data that was provided to them. And I think somebody needs to teach them that they have to get to know the patient before they give something. And also, another thing is, some of them, ID person has seen them in the hospital, and they're asking us how long to treat them. And they really should be taught to reach back to the ID physician who has seen them in the hospital setting, so that, because I don't want to contradict what were put in the initial concept.
That's right. Thank you so much, Dr. Chowdhury, for that. And Marty, I'll let you speak, and then I know that we have 2 other groups to get to as well.
I'm an addiction medicine physician, and there's 2 of us actually, and wanted to encourage any of you to, if you're dealing with someone who is using alcohol, it'd be fine for that person to ask a consult about how to approach that person where they are, use a little motivational interviewing. And Kevin and I are both really ready, willing, and able to help you. Addiction medicine is a new recognized subspecialty of the American Board of Preventive Medicine. That's all. Thanks.
Great. Thanks, Marty. That's wonderful. Great. So we'll move on to group 7, and that's Charles Neiditz, Joan Lister, and John Takahashi. Let's see.
I can say something if you want. We discussed the do's and don'ts, and certainly we were all on the same page. I think there's a trust issue with mentees that allow a didactic discussion back and forth like a consult should be. I think that one of the problems we said was that there needs to be a defined question to be asked in a consult. And I think Joan has done probably more than the rest of us in our little group consults. But I think asking a definitive question rather than a global, how would I treat this patient, I think makes for a better consult. I also thought, and the group agreed, that maybe the specialists need to also put a subspecialty interest to make consults better. And I don't know if Scott agrees with this, but the ability to, let's say, have an endocrine consult. You don't want to send an endocrine consult to a reproductive endocrinologist if you want an adrenal tumor evaluation consult. So if there's a particular interest, a cardiologist who has rhythm disturbances more than angina or valvular heart disease, it might be best to steer a consult to some specialist that has an interest in a particular field that might benefit their consult. But I think the question being asked, as Lois said, there's a trust that we have in our mentees, and we have a great discussion. Oftentimes the mentees will call us up and ask a particular question about treatment. And I think we don't have that trust in a consult because we've only done it for the first time or maybe only one time. John, do you have anything to say?
I think you covered it.
Oh.
Great. Thank you so much. And last but not least, group 9. This is Gerson Bernhard, Jill Silverman, and Bob Goldfein. Oh, Gers, you're on mute.
We concur very much with everybody else's concerns. Lack of sufficient information, frustration about not getting follow-up. And specifically for rheumatology, we get the battery of tests with little good clinical information, and therefore we're left at sea as to how to respond. And we don't want to be necessarily give them a textbook on rheumatology. That's not the reason for the response. We agree with all what are the complaints and problems and issues that everybody else has observed. And one other item we could add is sometimes when they say, well, we can't get a consult in rheumatology for 4 months, or we don't have one around at all, if you know a little more about where they are and where they might get their consultations, we can offer the option of perhaps getting in touch with their consultants and expediting the consultation when we think it's an urgent issue. And an issue that should be seen and by a specific clinician. In other words, it should be seen by the specialist and not handled as an e-consult. Do we have anything else, Jill or Bob, you want to add to that?
I think that's good. I think one of my take-home messages that I will take home is that offering my cell phone for text exchange, I think is a good idea.
Yeah, I've offered that a number of times, and rarely have they responded. And both Jill and I have observed that even though we've almost always say to patient, please follow up or etc., we rarely get those follow-ups.
Yeah. Great. And then just one, like officially, we discourage you not to have interactions via your cell phone, but the caveat being, if you do end up doing that, and I don't hear about it, if it just always make sure to let us know if it's in regards to a new consult, again, because we want to capture your impact and we don't want them to get in the habit of like reaching out to you directly via your phone. But I think in terms of like, like David, was saying, and the rheumatologist was saying, I think I think it's fine for that, that kind of quick follow-up, as long as it's related to the same case.
Yeah, almost always I respond in terms of, please get back to me on this platform.
Great. That's good. And then I just wanted to address, there were two questions. One was, does receiving too much information from the provider put the volunteers at more of a liability risk? And I just wanted to reiterate that when a clinic signs a contract with MAVEN Project, they're made aware of the construct that we're based on is that our volunteers are not caring for the patient. It is the provider's responsibility to care for the patient, and that our volunteers are in an advisory role, a curbside consult role, and that you're all covered under our umbrella liability policy. And we haven't had any claims made against us since we've been founded in 2014. So again, we don't have control over visualizing their charts to know what they put in. Sometimes they'll maybe copy and paste, just a section of what you've said. Sometimes they say that they've, checked in with a MAVEN volunteer, and sometimes they may end up utilizing your name, even though we discourage that into the chart. But again, the liability policy covers that, and that you're in an advisory role. And actually for every consult, when they are about to submit their consult, there's language that they have to check a box that reminds them that it's their responsibility. So I just wanted to reiterate that. I know that this was just fantastic feedback from everybody, and I'm going to just turn it back over to Scott for our concluding words.
And thank you all for participating in this. Thank you for your input. And especially thank you, Jill, for all the work you do for MAVEN. Thank you, Kristen, because we're all volunteers. We're all retired guys. And this MAVEN project is such a blessing. I know it is to me, because it still allows me actually to keep up to date. I mean, I keep up to date with stuff now that I wouldn't normally do, but also even more than that, it is such a blessing that we're still relevant to the world.
You're here.
Amen to that.
Thank you.
Thank you.
Wonderful. Well, Dr. Abramson, thank you so much for your interest in helping MAVEN Project and helping all of us and working with your MAVEN Project peers, especially in the areas of communications. And, actually Scott was the one that came to me and says, I have all of these ideas, and he had already put it together. And this was just aligned and dovetailed so nicely with what we were working on internally with MAVEN Projects. I'm eternally grateful to Scott for that. We will send out a copy of Scott's slides, a copy of the recording, that you'll have that as well. And thank you all for what you do for MAVEN Project. And we're so appreciative of you all. I hope that you all have a great week, and look forward to seeing you